In today's session, we will be covering chest trauma. And chest trauma is of serious concern. Every year, more than 700,000 emergency department visits involve chest trauma, and 18,000 deaths are involved. And basically, 1 in 4 trauma deaths are due to thoracic injuries. And that makes sense because of all the important organs and everything that is contained in the thoracic cavity. So it's regardless of mechanism, 25% of trauma deaths are due to chest trauma. And that's because, again, our ABCs are directly affected. Of those, most are actually managed without surgery. 90% of blunt trauma and 70% of penetrating trauma can be managed without surgery. And early deaths occur within 30 minutes to 3 hours. Early deaths that are preventable, that is, occur within 30 minutes to 3 hours. Those include pneumos, airway issues, hemorrhage, and what that means is that we can actually help in the field. You know, if most of these are managed without surgery, and if most of those are, or if there's a good number of those that are preventable within 30 minutes to 3 hours, that's our time frame, right? So we can actually make a huge impact there. When you take a look at our chest injuries, we're really looking at 4 different types of injuries. We're looking at skeletal or chest wall injuries. We're looking at pulmonary issues, cardiac, and so heart and great vessel issues, or issues with the diaphragm and some other items that make up that region or are found in that region, like the trachea and the esophagus as well. When we look at this this system, in fact, I'll actually go back to here. You know, we see all of these layers that are put on to protect the organs that lay in the chest cavity. So look at all of the bony structures, all of the muscles that we see that are all meant to protect that chest cavity. Which is because it's such important muscles or such important organs lie underneath there. So it does make sense that we try to protect that. When we look at, you know, our diaphragm placement, you know, we talk about it being under the 4th or 5th rib, but it actually expands down when we take a breath in. And this is important when we're talking about mechanism of injury and our cone of damage, you know, so what organs are actually being hit, if we have a penetrating trauma or if we have, you know, blunt trauma to an area. It also means that, you know, when we think about chest trauma, you could actually not only be hitting the lungs or the heart or some of those great vessels, but you could also hit some of what we usually consider our abdominal organs, you know, so the liver extends into this region. The kidneys are in the back in that same area, the spleen, the stomach. So we could have abdominal injuries in addition to our chest cavity issues that we have to watch out for. Alright, and this is basically, you know, just discussing what we just saw in those pictures. Alright, why is it so important? Again, it's so important because this area affects our ABCs. Has to be well protected because of what it's protecting. It's everything that we need for life. Our lungs to bring in oxygen, our heart to circulate that oxygen out to the body. And, you know, we have direct impacts on our ventilation, on our oxygenation, and on our circulation. We typically consider two major mechanisms of injury, and they can be combined when we talk about blast injuries, but penetrating is something that actually penetrates the wall of the body, goes from the outside and penetrates into the inside. Usually we're talking about, knife injuries, bullet wounds, just random things being impaled in someone. So those forces are usually directed in that smaller object that is making their way into the body, as opposed to blunt trauma, which tends to have that force spread out over a larger area. But this, again, blunt trauma can cause fractures, bruises. You can have shearing issues on our great vessels because of the blunt force. And you can have, same thing with the organs, they can be torn from attachment just due to blunt force. Those broken ribs could go on to lacerate organs and cause further damage. And then blast injuries are kind of a combination of those two. So when we think of the actual shock wave from a blast, that's more of a blunt trauma. But then that secondary wave of objects that are being propelled by that blast tend to have, or can have, penetrating trauma that go along with it. When we think about injuries to this area, like we said, we think about not only issues on the airway side of the house, but also on the circulation side of the house. And obviously any of these issues can cause damage to those areas. In addition, to direct issues, you can also have atelectasis that results. You can have bruising that results, that again limits oxygen uptake, and damage to vessels can interrupt what's happening with the ability to send oxygen to the rest of the body. Alright, so to start things out, obviously we're always going to do our scene safety to start out with, and then that happens as soon as we get the call, right? So if you're called for somebody who has gunshot wound, instantly you should be thinking, is this scene safe for me to enter? Is law enforcement already on scene, and has it secured? Is the assailant secured? And so we want to make sure that we're being careful. Same thing with stab wounds or domestic violence calls. We want to make sure that our scene is safe before we enter. And with all traumas, we're looking to make sure that we're assessing what other resources we might need. So do we need fire on scene? Do we need police on scene? Do we need the electric company there? If somebody went into a pole. So we want to, try to determine what's going on and anticipate what some of our needs might be. If it's something that involves more than one patient, then we're going to, look at if we have to triage. We'll use, triage, or start triage to go through that. And a lot of our size up is really just trying to determine that mechanism of injury. And then we want to make sure that we put on the proper PPE based on what that mechanism is and based on how our scene presents. All right, as we're walking up, we're going to form a general impression. We're going to obviously be assessing our level of consciousness. And what's really important about all of our trauma assessments is that we're developing a plan and we stick to our plan. Do it the same way every time and you won't forget anything. You won't leave anything out. So as we're approaching our patient, we're thinking about, what's their level of consciousness. We're looking out over the body to see if we see any life threats, as we need to address life threats as soon as they are presented to us. So if we see blood spurting out of their thigh, then we need to stop that bleeding, right? As opposed to if, there's just blood oozing from their forehead. So we need to, make sure that we're looking over everything. we're going to take C-spine precautions, until we clear the need for C-spine or until we address it. And as we're there, we're looking down over the body. We want to expose, we want to be able to see everything, and we're going to take a look at the neck, looking to see if, well, first we're looking at the airway to see if our airway is open, patent, that we're moving air. We're taking a look at the neck to see if our trachea is midline, to see if we have any jugular vein distension, or if those veins are flat. When we're looking at looking at the chest, we're looking at symmetry of the chest wall in itself. We're also looking to see if there's equal chest rise and fall, if we have any paradoxical motion, do we have any bruising. So we're basically looking for all of our DCAP BTLS, right? And I would say in the chest in particular, we're also looking for TIC, and specifically addressing TIC, which is tenderness, instability, and crepitus, because we're looking for any fractures in those ribs. So we're palpating, we're putting our hands on the chest. We should have our fingers spread so that we have our thumbs are laying on the sternum and our fingers are spread around the entire chest wall. And we're going to evaluate as the patient breathes. Are we getting equal chest rise and fall? Are we feeling any crepitus? Are we feeling any instability in that area? Are they tender? As we're touching, do they have any spots that hurt more than others? Are we feeling any subcutaneous emphysema, which are those little air bubbles that can get tracked under the skin, which is indicative of there being some breach in either the trachea or in the lungs, with what's outside of it, and allowing air to seep in to the tissues. We're also looking for edema, looking for swelling in those areas. And obviously if we find any issues along the way, like I said before, with a life threat, you have to address it. So if our airway isn't open, we need to open that airway. If there's gurgling, then we're going to suction. If there's snoring respirations, we're going to do a airway maneuver to open that airway and get the tongue off the back of the throat, insert oral airways as needed. If we find an issue with that chest wall, we're going to address it immediately. Alright, you can also use percussion, as every time we're assessing our patients, we're going to look, listen, and feel. I don't see percussion being used in the field often, but if you were to percuss the chest, a hyperresonance would indicate that there's more air in that cavity. A dull sound or a hyporesonance would indicate that there's more fluid in that cavity. And then when we get an opportunity, we're going to be listening for lung sounds. Typically, this might happen as part of our secondary assessment, but if we suspect that the patient has a pneumo, or a pneumo that's transitioning to a tension pneumo, then we would get lung sounds even faster. And remember, it's so important to listen to each side, apex, apex, base, base, and do a direct compare between those two, because of the ability to hear sounds kind of echoing through the chest. So you want to make sure that you're doing a direct compare. Right. If we have any signs that show up as we're checking, if we see bruising, swelling, things that are indicative of soft tissue injury, we're going to note that. If we see paradoxical motion, or a flail segment, we have to note that. If we see retractions, work of breathing being increased, we're going to note it. If we have that subcutaneous emphysema, we're going to again note that. We're going to take all of these things into account because of its potential to compromise airway and breathing. All right, its potential to compromise the patient's ability to bring oxygen in and get it out to the body. All right, we're also, as we're up there at the head looking down, we're assessing our rate, our depth of breathing, their overall effort. Are we seeing those accessory muscles? Do we need to do something to address it? Do we need to, bag them? Do we need to apply O2? Do we need to, position them or use airway adjuncts or suction or put in advanced airways? Whatever we need to do to manage that process. We're also going to take a look at circulation as we're working our way down, and I like to take a carotid pulse as well as a radial pulse, just to compare the two. Maybe the carotid pulse is strong, but the radial pulse is weak and thready, and that's going to tell me if their blood pressures are dropping. All right. We're also obviously looking again, now that we're a little bit further along, for any signs of obvious bleeding, and finding out how the ABCs are, if our airway's intact, if we're controlling breathing, or if the patient is controlling it, and if how our circulation is doing is really going to help us to determine our mode of transport, whether this is a load and go, and where they're going to go. So this is just assessing for JVD. Remember, it's best to do that in the semi-Fowler's position, so at a 45-degree angle. But with our trauma patient, if we're worried about C-spine, we may not be able to put them in that angle. So we have to look for other signs and symptoms as well. Right. As part of our circulatory assessment, we should be, assessing our heart tones as well. And, that's going to, help us to recognize if those heart sounds are clear, if they're muffled, if they sound, abnormal. All right. And like I said, it's going to help us to decide if they are, a load and go, what our transport priority is, and where we're going to take our patient. If, we have a patient that's suffering from significant trauma, we're going to get them to a trauma unit. We're going to potentially think of, how fast do we have to get them there? Do we have to have flight? Can we do ground transports? And really anything in these life threats, we need to address right now. But they should also be, these things have to be addressed immediately, and these folks should definitely go to a trauma center. And then we also have to, take a look at, have our index of suspicion high for some of these other issues that maybe we can't see or don't present themselves as clearly as some of those other obvious injuries. Right? When we're going down in our survey, we should have our patient packaged up, have them in the squad. We're trying to get a history. We might need to get, a little bit of that history on scene, and then we need to, move into the squad and gain the rest of it. Remember, we have to be concerned with that platinum 10 and our golden hour. The thought process being there is no more than 10 minutes on scene in order to, package them up, get the information that you need in order to treat your patients, and get en route in the facility so that they can have a need addressed within that first hour. If they do need to go to surgery, we want that to happen within that hour. So we need to move it along as quickly as possible. A lot of our questions are going to kind of revolve around what that mechanism of injury was. When we're talking about events leading up to the situation, we're really focusing on what that mechanism is. How fast were they driving? How far did they fall? What kind of surface did they fall onto? Those are what our questions are going to focus on. We're looking at, if there was a weapon, what type of weapon was used. If they were stabbed with a knife, well, how big is that knife? How long is the blade? Because that's going to determine our cone of damage, our cone of injury. So if you imagine that a knife being impaled into someone and then being able to turn it anywhere that knife could turn to as we rotate our wrist, we have to think about those organs, those vessels, those structures that could be damaged to go along with that. Okay, so as far as our secondary assessment goes, we're going to do a full head-to-toe assessment. So even you're going to go back over the head, just going more in depth. Now we're looking at the eyes, we're looking at the pupils, we're looking in the nose and the mouth for any fluids, broken teeth, looking in the ears for any fluid loss, working our way down, again going over the entire body, listening and feeling everything to figure out what's happening. We're also going to get a full set of vitals, going to get them on the monitor, and go through the whole process. Obviously, if it's an isolated injury, then we're going to do a focused exam right on where that injury is. If they were only, struck by something on the side in the chest, then we would just look there. Oftentimes, though, especially with thoracic injuries, they warrant a full body assessment, which, is if there's, some sort of significant trauma. And obviously we're looking for DCAP BTLS over the entire body. Let's see. That's basically what that says. And then we're going to reassess, right? So we constantly need to reassess, we need to reevaluate, and the frequency in which we do that is dependent on how they're doing. If they're unstable, we're going to basically start our reassessment right after we finish our last assessment. And certainly no longer than 5 minutes apart. If they're stable and, we have no real worries that they're going to remain stable, or they're not going to remain stable, then we can stretch that out for a reassessment every 15 minutes. Our overall management for our patients is obviously, for all of our patients, is focusing on the ABCs, making sure that their airway stays open, that they're breathing sufficiently, or that we're supporting them in their breathing, and that we're supporting their circulatory system. So starting IVs, getting fluids on board, preventing bleeding or stopping bleeding, and going from there. And then obviously, depending on their severity, to get them to the appropriate facility quickly for definitive care. And, just similar to, how we've already been managing our patients, is we're going to, use a jaw thrust instead of a head tilt chin lift if we suspect there's a spinal issue or the C-spine's been compromised. And then if there's facial injury, we wouldn't want to use any nasal airways. So we would, be concerned with that and want to watch for that. All right. We will look at providing medications. We might have to manage their airways, and in order to do that, we might have to sedate them. So we could look at meds for that. We might also, these can be very painful injuries, so we would look at pain management, which has been laid out. Obviously, depending on the level of consciousness of your patient would depend on whether or not, you need any of these meds. Another med that we would look at for potential bleeding would be TXA, and we'll talk about that shortly as well. Anytime we can splint an injury, keep the patient from moving, we help to, one, alleviate their pain, which decreases the amount of time they need for healing. It also potentially avoids further damage and further injury. If it also can help us with controlling bleeding. We can also do cold packs to reduce swelling and reduce pain. And then also just be careful with how you're handling them, especially when you start to talk about rib fractures and things like that. That person might be fully alert and oriented, and those can be very painful. We also want to transport them to the appropriate facility, so if they need to go to a level 1 trauma center, we would take them there. If they're unstable and we can't manage them in the back, then we would go to the closest facility and then just have them transported out from there. But if we're managing them appropriately and successfully, and our trauma center is 5 extra minutes versus our closer hospital, we might go ahead and go the extra 5 minutes to that trauma center. If they're very unstable and we're managing them but suspect that they could go downhill very quickly, maybe we just go to the closest facility, let them manage them and continue to stabilize them, and do an interfacility transport over to the trauma center. We've talked already a little bit about that golden period or golden hour, that first hour after the injury, in which if they can get definitive care, they have a much greater chance for survival, and that includes one, just living, and then also function. So being able to carry on with their typical life functions. And then we always talk about our Platinum 10. We like to, if it's a load and go situation, be on scene for no longer than 10 minutes, and get en route and do anything that we can en route versus spending extra time on scene. Alright, so we'll talk a little bit about the different conditions. We'll start with our rib fractures, and you know what, I think I'm actually going to stop it here and then start a part 2. That way the videos aren't too large and they should upload a little bit faster and you can pick through them. So this will be our assessment and management video, and then we'll go through specific injuries and talk about those in part 2. So tune back in for part 2.